Mr. Chair, ladies and gentlemen, I'd like to thank you very much for the opportunity to present to you today. It's an honour to be asked to be the plenary speaker, and I recall with a lot of gratitude the time I had with you all in Taiwan in about 2016. Today I'm going to be talking about identifying palliative care needs in residential aged care. Just a little bit about me. I'm a GP. I retired from academia 2 years ago, and I live in Australia, which has some very well-known icons such as the Sydney Opera House, but probably most famous for its natural beauty, the beaches, the weather, and it's something that we're truly blessed with, along with some very unusual flora and fauna. So today I'd like to just have a quick refresher on the trajectories at the end of life, how we can prepare for the end of life, can we actually identify death early or coming death, how do you plan for care, and I'm going to introduce a couple of concepts, and then have a look at a project that was very influential in improving care in residential aged care facilities. And finally, a reminder of the importance of looking after the carers. So what does end-of-life care look like? Well, we're all probably familiar with trajectories of illness. Cancer has a trajectory where you have a slow deterioration over time and a rapid deterioration within a few days or maybe a week or two before death. But my colleague in Scotland, Scott Murray, and his team have also looked at the trajectories of psychological, social and spiritual care, elements of the person. And as you can see, there are reasonably well-defined dips in social, psychological and spiritual care. And they correspond with when the diagnosis is made, when the person has discharged from intensive treatment, when the disease recurs, and when this decline starts to happen. Contrast this with the trajectory in organ failure, where it's a relapsing and remitting condition over many years. And the psychological and social trajectories follow those relapses. From the recovery of relapse, you don't quite get to where you were before. You don't quite get to where you were before, and eventually the person can die in one of these relapses. You just don't know which one. And then the one that we're going to be talking mostly about today are frailty, and this can include multimorbidity, dementia, and you have a very slow, inexorable decline from a low base. And but interestingly, the spiritual, the psychological and the social tend to be maintained till very close to the end of their life. So we can do a lot to prepare for the end of life, but preparation has to be done in plenty of time, which means that we need to look at how palliative care fits into all of this. So this is a standard model for palliative care. It is a model where the disease treatment becomes less important with time as the disease becomes harder and harder to manage, and that palliative care starts to become more important as time goes on. But it should be introduced early around here, so that it is seen as an adjunct or an essential component of the total care over time. In fact, there are two types of palliative care. First one is we'll call type A, and it's in those last weeks and days when things start to get very challenged and dramatic. But there's a second one as well, which is a long way out, weeks to months. So in those last days, we have intense symptom control. We've got lots of distress. We have the care at the very end of their life, the patient's life, and potentially involvement in bereavement of the care of the relatives that are left behind. And that's what most people's view of palliative care is. And rightly so, it's a very important thing that's done, and it's by and large done very well. What about this other one, type B? Weeks or months out from the person dying. So you're recognising that death is inevitable. You just don't know when it's going to happen. And so you need a different type of care which anticipates what's going to happen. And that involves advanced care planning. It involves clinical care planning, which I'll explain later. And the whole aim of it is to be prepared for when the deterioration happens, and empowering the patient with knowledge and with tools to be able to manage the sorts of problems that we know are going to happen, and also to pay a lot of attention to the carers. To me, I think this is ideal end-of-life care, particularly outside of the realm of specialist palliative medicine. And maybe we need to call it something else, because palliative care is not really understood outside of those last few weeks of life. So here we have this graph again, but we can also see that as time goes on, we've got some aims that we've got to try to achieve. And the first aim is survival, trying to reverse the disease and helping to get the person over it so they can continue their life. But at some point that becomes obvious that this isn't not going to happen. And then we have to focus on maintaining function and maintaining well-being and minimising symptom distress. And what I'd like to put to you is that we need to think about finding this these people early in the piece so that those aims can actually be achieved. So can it be done? So there are a number of tools that can be used, and we've used two in our work. The first is the surprise question, which says, would you be surprised if this person were to die in the next 6 to 12 months? And if the answer is no, I would not be surprised, then that person is at risk. The second is the Supportive and Palliative Care Indicator Tool, or the SPICT. And this is a tool which goes into more depth. It looks for some general indicators of potential deterioration to death. And it's also looking for specific disease-related indications. So for each person that you use this tool, you're looking at the whole picture, but then you're focusing down on the disease itself. Now, using those, we asked the question, well, can you actually predict death? And in general practice, this is an important question because it's one that's not always asked. And we wanted to know whether it was possible to do it using tools. And as our comparator, we just used the intuition of the doctor without any indication or any support at all. So we looked at people over 70 because they're the ones who mostly die. And this is what we found. When we just used unguided intuition, we found that 5.4% of patients were identified as potentially being at risk of dying. When we used the surprise question as a screening tool, and then the SPICT for those who had been screened as positive. Then we found 11%, nearly 12% of people were identified as being at risk of dying. The actual number of people who died was 1.6% of those screened in one cohort and 1.1% in the other. And of those who were predicted to die, the pickup rate was 14% in the intervention group and 20% in the guided group. They are not very good figures. And when we look at the parameters of the tests, we find that the sensitivity of the guided tools was 52%. It was better at picking people up who are likely to die. But the positive predictive value, the actual usefulness of the test was only 14%. That means that 86% of people who were identified as potentially at risk of dying did not die. And with the unguided intuition, the sensitivity was a lot worse, but the pickup rate, the positive predictive value was actually better, but still not great. The negative predictive value is 98% in both cases. And so the good news is that if your doctor says you're not going to die in the next 6 to 12 months, he's probably right. But 14% pickup is much better than the 1.6% rate, the people who actually died. And that means that doing anything is better than doing nothing. But it also raises the question of whether predicting death is actually the right trigger. So another concept we thought about was the possibility of predicting those who are dying by finding the elements of the SPIC that were most predictive and seeing if we could do something with that. And so we did a case control study where we looked at those who died both in the data set that we collected with the previous study and with the deaths of in 3 very large practices in Queensland, Australia. And we found around 270 deaths, and we matched people who were of the same age and gender who did not die in that time frame and looked at where the differences were. And our statistician managed to make a thing called a Nomogram, which had a wonderful consequence. That is that he was able to weight the risk of dying. We found 9 elements that predicted dying, but what he was able to show was that if you added up the scores related to each of those predictors, we actually ended up with a total score, and that could be converted into a proportionate risk of dying within the next 6 to 12 months. So for example, if someone had a score, when you add all these things up, of 170, then we're saying that you have a 45% chance of dying in the next 6 to 12 months. If you had a score of 60, then you had just over 10% chance. And what that does means it allows you to mount a proportionate response. If you've got a low risk of dying in the next 6 to 12 months, well, you don't have to do everything for this person. You can achieve very good preparation with basic preparation, basic planning. But if the risk is 60, 70, 80%, well, then obviously the degree of preparation has to be much higher. Also note that neurological deterioration, particularly dementia, actually was protective against dying in the next 6 to 12 months, which is really unusual. But we believe that the reason for that is that when someone becomes severely demented, they end up in high care aged care facilities, and they're getting a lot better nutrition, a lot better care, lower risk of falls and so on. And that actually protects them from dying. So it hasn't been tested in aged care, residential aged care. And the other thing that's really, I think, interesting is whether that neurological protection, the deterioration of neurology is protective, is actually a feature of Western society where we're individualistic and not so much family oriented, and therefore much less likely to be looking after our aged care within the family. They're likely to be living on their own. Whereas in the East, with a family structure much different, our older folk are your older folk are likely to be living with family and therefore at less risk of things. So, can you identify early in residential aged care? And this was a project that we did some years ago now, where we asked directors of nursing to screen for potential death using exactly the same process. And two directors of nursing, 2 nursing homes, 187 residents. And in that time, 42 residents died. And there were 80 residents who were predicted to die. So that ended up being 37.5% of the people who were predicted to die actually did die. And interestingly, 11% of those who predicted not to die did die. So it's better, but it's still not great. The prevalence of death was 22%. The sensitivity of the SPICT was 71%. The specificity was poor, but much better predictive values. Now, why the difference? The difference relates to prevalence. So in general practice, in the ambulant population, people over 70 had a 3.3% risk of dying in a year. In the residential aged care setting, that is 22%. And that means that the number of false positives is going to end up far lower. And the positive predictive value is almost 3 times higher. So it's much more useful to do this kind of screening in the aged care setting where death is actually a lot more prevalent. So how do we plan care? And this is my mum and my dad. My mum died in May and my dad died in July. So mum was just a few days away from death. That's my sister. So here we have our graph again, and we have our goals of care. And what I'd like to put to you is that aged care actually means if you're in aged care, you are already at risk of dying. The likelihood that you're going to survive long periods is far reduced. And so the focus needs to be on maintaining function and well-being and symptom control. Obviously, you don't stop trying to help people to stay stable, but you're not aiming to, quote, cure them. Now, what happens if you don't set goals? Well, care continues as it did before. Frequently, because you're focusing on the medical, you're not focusing necessarily on the changes that are occurring, and you're definitely not focusing on mental health, psychological state, spiritual state, social interactivity, and so on. And when you finally decide that a patient can't be cured, and you then switch to a palliative mode, the end becomes very rapid and unexpected. And palliative care is really partial at best. So this is what we're looking at. We're trying to extend survival. We're trying to keep the person alive. And eventually we say we can't do it. And we forget about function. We minimise risk well-being and symptom control because we're not thinking about it. And we end up with a very small window for end-of-life care to take place, and it often is not very effective as a result. No wonder that it gets a bad reputation. So how do you plan? Well, you have to assess, you have to plan, you have to coordinate. And I would put to you that planning looks like this. You're looking ahead. You want to hear what the patient's wishes are. And out of that comes advanced health directives, which are written instructions on what the patient wants. Very, very important. But at the same time, you have clinical care planning. You know, as a clinician, that things are going to go wrong. You know, with some certainty, what's going to go wrong. And so you can actually plan ahead for those things. And then the delivery, and that takes into account what the person wants, of course, and then you deliver the care. So there's actually these two elements. Let's have a look at them. So advanced care planning provides people with the opportunity to express their wishes in writing and for the sort of treatment they want when they can't express those wishes for themselves. They also get the chance to appoint trusted individuals who can make decisions on the knowledge that they have of what the person would probably want. And if decision making is unclear and it's difficult. And this is a legally binding document. Now in Taiwan, that was introduced in December of 2015. And quite a bit of work's been done to show that it's feasible to do it in hospitals. The sorts of people who get it are people with a higher likelihood of death. So these are people who are ill in hospital and there's a possibility of that person not surviving. And in aged care, same sort of thing was looked at. And relatively speaking, the numbers were not that great, given that most people in aged care facilities are at the end of their life. Only 39% had advanced health directives, and nearly all of those were completed by their relatives and friends and not the patient themselves. So we do have a problem. We also look at the reasons for what was being put into the advanced health directives, and it almost exclusively equals do not resuscitate in this particular study. It was uncommon. The people who had the advanced health directives were actually more likely to have interventions and admissions, probably because they're more ill. They were more likely to have a nasogastric tube, and they were at higher risk of dying. So they were identified as people who are going to die fairly soon, and this was preparation for that. But it was all about not allowing resuscitation under those circumstances. And that's very good because as a rule of thumb, the best outcome you're going to get from resuscitation is the way you were the day before you arrested. So if your quality of life and your physical well-being is quite poor the day before you have an arrest, then it's a very good chance that that's the best you'll do. In fact, you're probably going to do a lot worse because you'll have added hypoxic brain injury to the whole thing. So questions arising from this in my mind, and something potentially we can talk about later. What are the contents of advanced health directives in Taiwan? Is it just do not resuscitate, or does it canvass other sorts of treatments? Why are people in aged care facilities having nasogastric tubes and intubation? What's the purpose of them? How's that improving their life? And what's the role of culture in all of this? Obviously, I'm seeing this from a Western perspective. Having a Chinese cultural perspective, it might look totally different. In Australia, advanced health directives are done much earlier, and the nature of the forms allows the person to describe what's important to them and what kind of treatments they do and do not want, which includes resuscitation, but it also includes things like artificial hydration and nutrition and life-saving surgery. Most people who fill them out do not want to be kept alive if major interventions don't reverse them back to a good state of health, and would rather die at home, or if you live in a residential aged care facility, to die there and not be sent to hospital. And quality of life and general well-being are really the things that dictate the decisions. And many aged care facilities actually expect an advanced health directive to be done when the person's admitted. In Ipswich, where I work, in around 2012, the local hospital decided to appoint a nurse just to find these people who were from aged care facilities and help them to consider and complete advanced health directives. Every single one of them who ended up in a ward had that done. And then the nurse went out to the aged care facilities and did the same thing with every resident. And as a result, this saved the hospital approximately $1.4 million per annum, because people who would have ended up in hospital stayed at the home, which was their preference. And the cost for that was one nurse and one car. So it's been very effective, and it's now expanded to include 3 advanced care planning nurses, sorry. But it does put a lot of pressure on palliative care to do palliative care onto Australian aged care homes. And that is a real problem, because Australia's funding of aged care facilities is a national disgrace. We've just had a Royal Commission into this, and we are woefully underfunding our aged care facilities. And we're not focusing on the person as a person, by and large, but we're actually funding on the basis of medical unwellness. And that has a lot of consequences. The main ones are to do with the skilled staff. Trained staff are expensive, and so there's very few of them. Most of the care is actually undertaken by what are called personal care workers, who have no training in clinical matters. And so you're putting a lot of pressure on very few people to identify potential problems and then manage them. And often they're doing that with no training and are very fearful of doing the wrong thing. So the default is to send the person to hospital. This creates poor morale. Pay is terrible relative to other sectors in aged care, in health, and so there's a high turnover of staff. And out of hours, it can be difficult to find a doctor. So if there's no plan, there's no treatment. Clinical care planning, looking at the things that we know are going to happen, can include physical conditions such as that list there, and can be dealt with. Psychosocial and spiritual issues, I think, is very largely ignored. If you've got a poorly functioning body but a very intact mind, and isolation, boredom, distress at being potentially less useful, if you like, and the fact that you're heading towards death and you may not be ready for that. All of those things are very real, and but also very difficult to deal with in a low funding environment. And so people at aged care are in a very bad position. But with planning, it's like an umbrella on a rainy day. If you do it, then you're going to do well. If you don't, you're in trouble. So if you don't plan, it looks like this. And if you do, hopefully it looks like this. Clinical care planning doesn't mean stopping active treatment. It can be done in parallel to ongoing management, but it does mean you've got to keep looking at the patient, and you've got to have plans ready for when things start to go wrong. And everyone's got to be on board, the patients, the carers, and particularly the health professional staff. They've got to be empowered to act appropriately and in a timely way. And there are ways of doing this. We have visiting specialists going to aged care facilities, covering a range of specialist interests. We have hospital in the home to try and keep people out of hospital for temporary things like cellulitis. And we have a nurse-led consulting service, which is what I'd like to talk about now. The question is, does the specialist who advises the nursing home have to be a doctor? And who are we trying to inform? Who are we trying to help? And so a service was put out there on a trial, and we evaluated that service. Patients who were seen as approaching the end of life were referred to the service by nursing homes. And then the patient was evaluated by a senior nurse with palliative care expertise. And that nurse would talk to the patient, if possible, the family, the staff, and the GP, and come up with a plan that was agreed to by everyone. It was the aged care staff that enacted the plan. It wasn't the specialist nurse, but the specialist nurse mentored the aged care staff. So over time, they started to get used to and comfortable with palliative care type treatments. And the idea was to empower the nursing staff to be able to do the work on their own without support in time. So there were 44 deaths in the 12 months after the program started. Of those, 28 were referred. And we look at some of the parameters in the 12 months before, comparing it with the 12 months with the program, and we find some remarkable results. Hospitalisations more than halved. The frequency of symptoms actually being managed and that being recorded increased by a factor of 3. There was some formal increase in formal planning, but not significant. But informal planning, just notes in the chart, went from 50% to nearly 100%. We had a learning effect. So these people who weren't referred also showed some improvements. Still substantial numbers were hospitalised, but the number of times that symptoms were managed increased. They doubled, more than doubled, and informal planning, pre-service, that should be 50%. Went up to 75%. So there, again, lots of evidence that these nurses actually learnt from having been involved with people who were referred. And when we look at the reason for admissions, we find that a lot of the things that could have been treated at the nursing home were referred in the 12 months prior to the service starting, and that dropped enormously when the service started. So the judgment of people was way better. And I think that's a real credit to the service itself and also to the staff who learnt along the way. The qualitative comments were uniformly positive. Mostly the nursing staff were happy to have orders written by the GP ahead of time so that they weren't scrambling out of hours to try and get what they needed. And that created a lot more confidence. It also meant that there was a lot less need to refer to out of hours doctors who were just not capable of helping because they didn't know the patients. And the time taken to respond was also very slow. So over the time, the nurses became more confident, and they recognised that before they had their before they had this service, they weren't confident. They didn't know how to use the treatments and what to do. And afterwards, they did. Far better support. The families felt more supported. The staff felt more supported. There was better coordination. They were able to respond in a timely way. It was a much better situation. Now, finally, let's talk about carers. Caring is stressful. And even when a person ends up in an aged care facility, the stress on the immediate relatives is very substantial because they feel the need to come on a regular basis, which is important, but that brings with it a lot of costs, like neglecting your own health, fear of what's happening and what's not, they don't know what's going to happen. The opportunity costs, while they're at the nursing home, they're not being paid if they're in paid employment. And of course, the relationship changes, and there was a much more close and intimate relationship between next of kin and the older and this ill person. Now it's more a relationship of visiting someone in a hospital setting, and it's very artificial. It's carers and no one's formal responsibility, and that's what I'd like to raise. But we really need to make them our responsibility. If it's not us, it should be the GP or someone that sees that carer on a regular basis. And we've done work, and we've done an RCT to do this in cancer patients, and we were able to identify a lot more needs of the patient, of the carer, and that gives us a chance to address them. So this is actually available, this form. It is basically allowing a guided consultation with the doctor. These are the things this person's worried about. These are the things the person is most worried about. And these are the things that can be addressed. So in summary, all of people in residential aged care are at the end of their life. And so recognition that they are going to deteriorate is important. It doesn't mean that you have to do everything for everyone, but if you can identify those people who are starting to develop a more rapid trajectory, you should be doing a plan for them. And as they get ill, you can escalate that plan very quickly. Planning includes advanced health directives, and I'd really encourage that to be done early in the admission to an aged care facility, not late. Clinical care planning, think ahead. It's not that different to what you do. It's just that you're trying to anticipate what's going on. And nurse-led expertise can deliver great outcomes. And don't forget to care for the carers. Thanks for your attention. And I'm very happy to answer questions.